Thank you, Kendra. And thanks for having me here. I'm really happy to speak to all of you about this topic of COVID-19 vaccines in children. I am a clinician. Most of my work, 95% of my time, is spent in a primary care practice here in Newark, and I've been doing this for 25 years. So my focus is really going to be clinical. I'm not a scientist, so I'm not going to get into a lot of the details of the vaccine, but we'll go through some of the symptoms of COVID-19, the effects of this pandemic on kids. We'll touch on that. And then I'd also like to go through some of the things that we can do as providers of healthcare, as well as public health providers, to increase uptake of vaccines and to try to make families and kids more comfortable receiving this important treatment that they can use to avoid illness and death that we've seen during the pandemic. So I do have two disclosures. I do have a financial interest in stocks in Johnson & Johnson, and I participated in a clinical trial of varenicline for adolescents to stop smoking, and that was funded by Pfizer. That has ended a few years ago. So as Kendra mentioned, these are the objectives for the talk. I want to talk about the role of vaccines for children during the COVID pandemic. We'll describe the current recommendations for COVID-19 immunization of children, and then go into the clinical approach to COVID-19. I'll also spend a little bit of time talking about the effects of the disease, just to set the stage, as well as the long-term effects of COVID-19 illness in children and families and their effects on the children themselves. And this talk should take about 35, 40 minutes, so there'll be plenty of time at the end for questions, and hopefully people will have comments as well as questions, and we can have a discussion at the end of the talk. So, and I apologize if some of this is stuff that you've heard multiple times. I know most of you have probably attended many talks on COVID-19, but I just wanted to summarize some of the background information before we got into the vaccine itself. So we know that the cause of the disease we call COVID-19 is a SARS-CoV-2 virus. It's from the family of coronaviruses, and these are common viruses that cause colds and mild illnesses in children and adults, and it's a very, very common virus. It is a virus that spreads very quickly from person to person. It spreads by droplets through breathing, coughing, sneezing, or speaking. And we've all heard about the spike proteins, and I'm sure many of you have seen pictures of the virus on the electron micrograms that they like to publish. And it gets its name as the coronavirus or crown because the spike proteins kind of stud the outside of the virus and make it look like a crown. And so those spike proteins are the proteins that are visible or presented to our body's cells, and that's what the body reacts to in its immune response. And the spike proteins are what changes during cell replication and causes the different variants that we've heard of. So we need to keep up with those natural changes in the spike proteins as we continue to develop vaccines, and in the future maybe need to modify vaccines to be effective against the new variants that develop. Variants develop naturally in all microorganisms, viruses and bacteria, but particularly in viruses as they replicate. And so the more replication that takes place over time, the more chance there is for variants to develop. And by chance, more of those variants may be more pathogenic or more able to cause disease and to cause severe disease. And so the more we can prevent spread of the viruses through masking and distancing and things like that, or through vaccines, the more we'll be able to prevent this replication and development of more important variants as time goes on. So the disease COVID-19, many of us are familiar with the basic symptoms. It causes a very kind of general viral picture in most people. So it's very hard to distinguish it clinically, especially in the beginning, from common cold or a flu. It causes fever or chills, cough, shortness of breath, difficulty breathing. It can cause general complaints like fatigue, muscle or body aches, and headaches. One of the characteristic findings in people with COVID-19 is a new loss of taste or smell. And when we see that, we're really much more likely to encounter COVID-19 as the cause of the illness. It causes sore throat, congestion, runny nose, nausea, vomiting, and diarrhea. And particularly in kids, we see many infants and toddlers who their main presentation is the vomiting and diarrhea without much of the respiratory symptoms. In addition to the acute illness, there are post-COVID conditions that occur in kids and adults. And so there are multi-organ system effects. There are long-term effects, for example, on the heart with pericardial inflammation, myocarditis. There's effects in the brain, and people complain of brain fog. They complain of difficulty with concentration, with memory. And then there are, of course, are the effects of having had COVID-19 illness and being hospitalized. So people present with symptoms of post-traumatic stress disorder, particularly because they're hospitalized and isolated, and especially in the beginning of the pandemic, weren't allowed to have visitors at all, and even the staff that came to visit them are all masked and gowned and protected. And so it's a very isolating experience that can last for weeks to months in some people, and can have those lingering effects. And then there are new or ongoing symptoms related to similar symptoms that are caused by COVID-19 in general. So people have chronic dyspnea and easy fatigue that can go on for months and months. Children do get infected with COVID-19, and although the general belief is, and the reality is, that most kids that get COVID-19 do very well and have mild disease, that's not to say that they don't get infected. We've seen 2 million cases of COVID-19 in kids from 5 to 11-year-olds out of a population in the US of about 28 million. So around 7 or 8% of kids have been infected with COVID-19. Some children do have more serious disease. Multisystem inflammatory syndrome in children is the name given to a generalized inflammatory response that children will get a month or so after having had a mild to moderate case of COVID-19. And they develop, as the name suggests, inflammation in many organs, in the brain, in the heart, in the lungs, in the kidneys, and they end up in intensive care, requiring pretty intensive treatment for a month or more. Most, thankfully, do recover from the condition, but they do also suffer post-COVID conditions. In children, the post-COVID conditions are similar to an adult, with effects on the heart, the lung, and the brain as the most common. In kids, this becomes important, especially when you have problems with memory and concentration, because kids in this age group are expected to attend school. They have to spend the day sitting still in the classroom and trying to concentrate on their schoolwork, do their homework after school, and it's a big part of their life, and this is something that really can interfere with, and especially a child who was doing well in school often can have problems afterwards from having had COVID. Kids themselves will also suffer the effects of their parents and caregivers who have had COVID. And so it's a scary time for families. It's particularly scary for younger kids who maybe don't understand everything that's going on and often aren't included in family discussions about what's happening to their relatives and their caregivers. There was an article just this morning, I don't know if any of you've seen it, on the New York Times, about kids who've lost family members to COVID, and about 167,000 children have lost either a parent or a primary caregiver to COVID-19, and 70% of those were kids under the age of 13. And so there's an entire realm of investigation and treatment related to the mental health effects of COVID-19 on kids that, as public health practitioners, we need to kind of take on and help develop programs and make treatments available to them. We need to obtain funding for it so that kids can receive the care that they need in this regard as well. So as I mentioned, it's an easily spread virus. So how do we protect ourselves? First of all, wear a mask, and these should be a well-fitting mask, ideally either a well-fitting surgical mask or an N95 mask if you're going to be in close contact. This distance of 6 feet apart seems to help prevent some of the spread of COVID that's being transmitted by droplets from person to person. Of course, common sense things like avoiding crowded areas and avoiding poorly ventilated areas where COVID-19 can be easily spread is going to help. Getting tested is important because we need to know who has COVID-19. And so when you have a mild illness, and it's very, like I said, very difficult to tell whether it is just a common cold or the flu or something else, if you get tested and you know that you're infected, then you can isolate yourself to prevent spread to other people. And so this often involves convincing families that the test is accurate and that they really do have COVID and they really do need to isolate or quarantine. And so often the discussion in clinic or by phone with patients that we have is that the child already missed so much school. Do I really need to keep them out of school when they don't seem that sick just because the test is positive? Maybe it was a false positive, but we would need to test if there's a reason and then rely on the results of the test and insist on quarantine and isolation to prevent further spread of the disease. Washing hands and disinfecting surfaces can also prevent some of the spread of the disease. And then the most important tool that we have now in order to prevent the spread of COVID is getting vaccinated. So that'll be the remainder of this talk, is to talk about how we can help kids and families do that. So vaccination is a way to stimulate the body's immune system to produce protection in the form of protective antibodies and protective T cells so that when a natural infection occurs, the patient is already primed and they can attack and kill that virus before it has a chance to replicate and cause disease. And so the two main immune system cells that we're interested in are B lymphocytes, which are the part of the immune system that produces antibodies that then bind. They recognize those spike proteins, bind to them, and allow that viral particle to be then destroyed. And then there are also T cells that attack cells in the body that have become infected. And these are responsible for they're part of the memory cell system that even when there are no detectable antibodies in the blood of a patient, the body still has some memory against that infection and can call up T cells and then begin to call up B cells and produce antibodies very quickly if a person is infected, even months or sometimes years distant to that initial vaccination. So COVID-19, there are several types of vaccines available. The three that have been most successful are the mRNA vaccines, the viral vector vaccines, and protein subunit vaccines. So in the United States, the three products that we have right now are two mRNA vaccines, the Pfizer and the Moderna, and then the viral vector vaccine that we use here in the US is the J&J Janssen vaccine. Protein subunit vaccines are used in other places. We don't have any license right now in the United States. So we'll talk mostly about the mRNA vaccines. The viral vector uses a different virus, an adenovirus, and the DNA is modified in the virus to produce the spike protein antigens that are part of COVID, so that the body will recognize that replicating virus and the immune system will attack it and develop resistance to the COVID-19. mRNA is a newer technology, so I'll spend a few minutes going through it with you in kind of a simplified fashion just to make sure everybody understands it. And because we do get a lot of questions from patients about what an mRNA vaccine is, and is it safe? It's so new, so we'll talk a little bit about that. And first of all, it's important to realize that even though these are new vaccines and even though they were developed quickly, that doesn't mean that they were developed kind of de novo in a too quick fashion. So no steps were skipped in the production of these vaccines, and the mRNA technology that formed the basis of the vaccines has been in development for over 10 years. Just had never been brought to a clinical application. So this was something that was waiting for the right use. As far as the steps taken to ensure effectiveness and safety of the vaccines, it's usually a multi-step process. And so the reason that it usually takes years to bring a product to market is because the steps are taken one by one, and you're not going to invest in the second step if the product failed in the first step. But in the case of COVID, because of the severity of the pandemic, all of the steps were done simultaneously for a large number of products, many of which didn't make it to market. If you remember at the beginning of the pandemic, they talked about 12 to 14 companies developing vaccines. And so a lot of investment was made to that. But each step was conducted, although simultaneously, it was conducted fully so that the safety and efficacy was the same as if it had taken a longer time to produce. So mRNA is messenger RNA. So it's something that all of us have in our cells. It's part of the machinery of our cells that is used to make proteins that are used for body functions. So this is something that is naturally occurring in our body. And the mRNA that is used is a messenger RNA that codes for the spike proteins of the coronavirus. So it's given as an injection into the deltoid muscle. The mRNA enters the muscle cells and then instructs the muscle cell machinery to make a piece of the spike protein inside the cell. Those spike proteins are then sent out to the surface of the muscle cell and displayed there so that the immune system can see those spike proteins, and it will trigger an immune response to those proteins, which are called antigens, to produce antibodies that then produce immunity. It also activates other immune cells like macrophages and T lymphocytes in the system to produce memory cells and help the process along. The mRNA vaccines are actually quite simple chemically. It contains the mRNA, it contains some fats, some sugars. In the adult vaccines, it contains, and in the kids' vaccines, it contains acid stabilizers. These acid stabilizers are buffering agents that make the vaccine able to be stored under general refrigeration for a longer period of time for the doses that are available for the 5 to 11-year-old children. And these components are all things that are commonly found in foods and other items that we commonly ingest. It's not a lot of foreign material. There are no preservatives or other things in the vaccines that might cause people to worry. Since they're not live, they cannot cause an infection, they can't replicate on their own, and they can only stimulate an immune response. It's important because people hear mRNA, there are a lot of concerns about how it might change a person's DNA. That's the reverse of what happens naturally. It doesn't interact with DNA. The mRNA does not enter the cell nucleus. It doesn't interact with a person's DNA in any way. And it's important to know that it doesn't remain in the body for a long period of time. So mRNA generally remains in the cell for a few days, and then the spike proteins remain in the body for a few weeks until they're cleared. And during that time, the immune system is working to develop immunity to the spike protein. So why do we vaccinate children? First of all, as I mentioned, many children can get very sick from COVID-19. They can have a severe illness. They can have a moderate illness or mild, but even kids with mild to moderate illness will lose days of school, and which is an important part of their daily life. Children can have short and long-term complications from COVID-19, as I mentioned, and importantly, children can serve as a reservoir to spread COVID-19 to others at home and at school, and especially because many children can have asymptomatic infections. They can easily spread the virus to other people, especially adults and older adults, without even knowing it. So if they're vaccinated, they're less likely to be infected and less likely to have large numbers of viral particles that they can spread to other people. And so vaccination will allow them to resume many of the normal activities of their daily life in a safe manner. There is one vaccine available for use for children ages 5 to 11, and that's the Pfizer vaccine. The dose is based on age, so it's not like many things in pediatrics, a dose that's based on body weight. So if a child is under the age of 12 and over the age of 5, they can get the pediatric dose. Once they turn 12, they get the full adult dose. And for kids who are given the first dose before they're 12 and the second dose after, they should get an age-appropriate dose for the age that they are when they receive that dose. It's given as a 2-dose series, just as in adults, 3 weeks apart. There right now is no booster recommendation for kids in this age group, but we'll see where that goes in the future. Most likely there will be. And it's important to know that it may be given with other vaccines. And this is something that changed initially. At first, there was a recommendation to wait a few weeks between giving a COVID vaccine and having had or going to get another vaccine. But we know now that it's safe and effective to give COVID vaccine along with a flu shot, for example, or any other vaccine that the kids are getting. Side effects are pretty minimal. So most of them are local pain, redness, and swelling, a little bit of fatigue. They may get some headache or muscle pain, fever, chills, and nausea. And these are all side effects that are pretty common with most vaccines that kids get. They last a day or two and often go away with just some rest and some Tylenol and time. There are, however, rare, severe reactions to the vaccine. Some people can have allergic reactions, and if you do have an anaphylactic reaction to a dose, obviously you wouldn't get a dose after that. In children, one of the major side effects that we've seen with the Pfizer vaccine is myocarditis. That's usually not in the 5 to 11-year-olds, but more in the 12 to 17-year-old boys, more common than girls, where they do get an inflammation of the heart muscle, and it can require hospitalization at times. It lasts a couple of weeks to a month, and in almost all cases, it does resolve completely with just some supportive care or with just time. But it is concerning. It's a handful of cases, though, out of millions of doses. And one thing that you'll hear parents bring up is, and that is available to us as providers, is that we can report adverse reactions of any type to the Federal Vaccine Adverse Event Reporting System, or VAERS. One way this comes up clinically is that parents will hear about this system and will sometimes bring up numbers of from the database that they've seen published or reported on websites or on the internet. The VAERS system is designed to collect any adverse event that happens after receiving a vaccine, but it doesn't mean that any of those adverse events were actually related to or caused by the vaccine. It's basically just that in time, something happened to a patient after they received a vaccine. And anyone can report into the system, and they can report any event that they or someone they are dealing with has experienced. And so those numbers, although very important, and it's an excellent system to capture data, are not conclusive in terms of deciding whether an adverse event was due to the vaccine or not. And so sometimes patients come in and say, look, several thousand people have died after getting a COVID vaccine. So they're worried that the COVID vaccine caused the death. That doesn't necessarily mean that that's true, and many of those patients may have died of something else. It just happened soon after getting the vaccine. So the vaccines are quite effective. These are some recent data from the CDC website, and so the CDC monitors the effectiveness of the vaccine in real time, and they publish on their website monthly statistics about the various vaccines in different populations. And that's because we're worried with different changes in variants that the vaccine effectiveness may change over time. And so in October, the vaccines overall of the 3 products, and this is in the population in general, were 85% effective at preventing hospitalization and 67% effective at preventing infection. So they're still working quite well, even with the variants, the Delta and the Omicron variants that are circulating now. And we do know that when we compare vaccinated and unvaccinated people, vaccinated people do much better in terms of avoiding COVID-19 infection and serious outcomes from COVID-19 infection. And so in September, it was noted that unvaccinated people were 5.8 times more likely to test positive for COVID-19 than vaccinated individuals, and 14 times as likely to die from COVID-19 as a vaccinated individual. Luckily for us as pediatricians, fully vaccinated 12 to 17-year-olds had the lowest case rates of all the age groups. And so the vaccine seems to work very well in this population, and we expect it to work very well in the younger kids also. We do hear about breakthrough infections, and so but breakthrough infections after vaccination are expected. As you saw, the effectiveness is not 100%. We never expected it to be 100%. And so just because someone might get COVID after a vaccine doesn't mean that the vaccine is not working in the population at large or even in that individual. And so we are preventing a good number of infections in the population, and we're also helping people have a more mild course and avoiding severe illness and death, even if the vaccine didn't prevent the infection completely. So fully vaccinated persons are less likely to develop serious disease, and the symptoms tend to be less serious. People with breakthrough infections can be infectious, and so they still need to quarantine and observe masking and other infection control procedures. And we know that the variants do affect the rate of breakthrough infections because the vaccines may become less effective against them. They may be more inherently infectious and spread more quickly. That doesn't mean that every variant that might spread more quickly is also more severe. So some variants might spread quickly but cause less serious disease. So those are all things that need to be watched, and the CDC monitors that and publishes it, and it's available to us as health providers to counsel our patients. The CDC has an app called VSafe, which is a smartphone-based tool that uses text messaging and links to web surveys for patients after they've had a vaccine. They can register for this, and then they can have health check-ins. It will send them messages. It's used to monitor vaccine safety, as well as it can provide dose reminders for the individual if they enter their information in after they've received their first or second dose. It'll tell them when they need another dose or a booster. So why don't people get vaccinated with COVID-19 vaccine, especially children? So many people are concerned that the vaccine might not be safe for children. We know that that's not true. It's been tested, and it's proven to be very safe. It's been, even in real life now, with almost a year's worth of experience, we've seen that the vaccine is very safe in the general population, and we have no reason to expect that it won't be safe for children as well. Some people believe that natural immunity is safer and even better than a vaccine because somehow having fought off the infection will produce better immunity. Natural immunity is real. After an infection, a person does have some protection, but we don't really know the dose of virus that the patient got during that infection and the level of protection that they had. And we also don't know how long that protection will last. And so even after natural infection, a person is recommended to get a vaccine in order to boost the immunity that they did receive by getting infected naturally. Some people have cited concerns that vaccines cause problems with fertility. Again, it's an mRNA vaccine. It doesn't enter and affect the DNA. There's no reason that it should affect the reproductive organs, but that is a myth that is out there. The NIH did recently provide some funding to look into the effect of COVID-19 vaccine on menstrual cycles, and we'll see the results of those studies, but it doesn't seem to affect fertility. Other reasons are that people don't want to get the vaccine for kids because kids don't get that sick from COVID-19 to begin with. And although that may be true generally, we do know that some kids do get sick and get very sick. There are children who have died from COVID-19, and children serve as a reservoir. And so even if the child isn't getting sick, they can spread the infection to those around them. And so it is still important for them to get vaccination. And then some people believe that vaccines cause variants, which is completely false. We know that the vaccine is not alive. It doesn't replicate. The mRNA that it gives to the patient is what it is, and it can't change into another variant. So vaccination after a COVID-19 infection, as I mentioned, is recommended because levels of natural immunity do vary. It's also important to know that no test can reliably determine the protection that a patient has after an infection from getting a future infection. And so people often request antibody tests, and they want to be able to use that information to decide whether they need a vaccine. Some people want to see whether they need a vaccine now versus maybe waiting a little longer. But there's the use of that test for that purpose really doesn't exist. We don't know how reliable it is. And also, you can have no antibodies detectable and still have some protection of that against infection because of those T cells. And so we can't use those tests for that purpose. We also know that those who remain unvaccinated after COVID-19 infection are 2 times more likely to get COVID-19 again than those who receive a vaccine after their infection. So the vaccines do work, and they work very well at preventing second infections. After a person has COVID-19, the question often comes up, how long do they have to wait before they receive a vaccine? And there are different recommendations floating around. But in reality, a person can get vaccinated as soon as their quarantine period ends and their symptoms have resolved in most cases. The only time when you would need to wait to get a vaccine is if you've received treatment with monoclonal antibodies or convalescent serum for COVID-19 or for prevention of infection if you were exposed. Also, children who have had multi-system inflammatory syndrome should wait 90 days to get the vaccine. It's not because the vaccine could be harmful to them, but it is that the vaccine may not work as well or at all because there may still be some antibodies or some antibodies from the convalescent serum in their system that would cause their body not to respond as well to the vaccine as you would like. And so those are the only cases where you would have to wait to give a vaccine after someone had COVID-19. So how do we get patients to receive the COVID-19 vaccine? First of all, we need to understand where patients are coming from. And I think in most cases, this is not such a hard sell for us as healthcare providers, because many of us were quite concerned about getting the vaccine when it first came out, and we share similar concerns with the patients. But you want to listen to their concerns with empathy, try to understand the individual concerns that each person has, because it's going to be different for different people, and really let the patient know that you do understand and appreciate and value their concerns, and you'd like to help them work through that. So the best way to explore concerns, as with any behavior modification or behavioral change that you'd like to help a patient undergo, is to use open-ended questions that allow the patient to express what they're thinking, what they believe, and what they're feeling from inside them, rather than leading them or trying to tell them what you think they should think or believe. You want to help a person explore why they would be motivated to get a vaccine. And so for different people, there are different reasons. And we've had people who, even though they're afraid to get a vaccine, they have someone in their family who has a serious illness or is elderly and lives with them, and that's the motivating factor. Others, they want to be able to go back to school in person because the child doesn't do well with at-home learning, and that's going to be a good reason for them to get vaccinated. So everyone might have a different reason why they would want to get the vaccine, but you want to try to find those reasons and then elevate that to the point where the patient then feels motivated to actually take the step and get the vaccine. You want to send everyone out, even those who are reluctant or completely against getting a vaccine, with a clear recommendation that you believe that it is the best thing for them to do and that they should get vaccinated. And so patients that I have and families that I have that are against vaccination in general or against the COVID vaccine in particular and feel very strongly about it, still leave the office with a clear recommendation that I believe they should get it, and that they know that we're going to talk about it again the next time that they come into the office. And it's not done in a way that is confrontational or belittling, but in a collaborative way where they do understand my concern for them, for their family, and for their health. And although we might disagree on what the best choice is, we respect each other, and they know that they're going to hear it again, and hopefully can come around to understanding and choosing what we do believe is the best thing for them. And then when you do have someone who wants to get the vaccine, have a place to send them. Right now, that's pretty easy because the vaccine is available free of charge to everyone, and is available widely in pharmacies and in vaccination centers. So here at University Hospital, we have a COVID-19 vaccine center that will give the vaccine to adults and children, and the hours are pretty flexible and wide. So the best person to offer information about the vaccine and to make a recommendation vaccine is going to be someone that a patient trusts. In many cases, the issue is not necessarily knowledge and information, although you do want to provide accurate knowledge and accurate information to a patient, and many of them are subject to misinformation, and that needs to be corrected. But many of the decisions that are made are based more on feelings, and so generating a sense of trust is going to go a long way to helping a patient get over their fear, listen to what the correct information is, and make a choice that will benefit them. And so often a person may not trust the medical establishment, But when we do surveys, we do see that patients do trust their healthcare provider, their doctor, their nurse, their support person in the healthcare community. And so that's the person that really can make a very big impact on them in providing that information. And often physicians in general don't like to talk about things that they think patients don't want to hear. And so, for example, we've seen this very reliably with flu vaccine, where patients say that they would like to hear about information about flu, and they expect the doctor to make a recommendation for it when they go for their visits. But a good percentage of physicians, about 30%, shy away from pursuing a recommendation or discussing flu vaccine with a reluctant patient because they don't feel the patient is interested in hearing about it and don't think that they'll be happy hearing about it and that it will be a bad experience. The opposite is true. Patients expect it, they want the information, and they want to know that you care about them and are willing to discuss even difficult topics with them. Related to that is we can and should engage community and family members who will support vaccination, and so faith-based initiatives are a big part of engaging communities. And in many families, engaging the decision maker, which may not be the parent in many cases, is the person that you need to win over. And so having the grandmother come in or making a phone call to her might help some families decide that they will get the vaccine. And then we need to explore with patients what their personal experience with healthcare, with vaccines, and with the COVID infection or vaccine is, so that we can help them make sense of those personal experiences. And I try to always have patients focus on their personal experience and not on what they're reading or hearing in the internet or in the news, because they'll often realize that what they're hearing is not in line with what they're really experiencing. And sometimes that makes a light bulb go on that, yes, maybe these things really aren't true, because nobody I know actually suffered from getting a COVID vaccine. And I know a lot of people that had the illness and did well. Excuse me. 1 second. Excuse me. So one thing that we hear a lot about nowadays is vaccine mandates. And we do want to bring patients around to accepting and asking for a vaccine on their own. And there are issues of autonomy and privacy that need to be balanced with the common good. And we want patients to accept responsibility for taking the vaccine because it's the right thing to do. However, sometimes mandates will go a long way. And personal responsibility is important, but one thing that I've found is that some patients really, on some level, and this is my personal experience, don't want to be responsible for making that decision. And if someone they trust tells them that they should do it, or even that they have to do it, they will do it. They will get the vaccine. And so we don't always want to say, well, it's up to you, but to tell them you should do this. I believe you should do this. And some people, that's enough for them to feel more confident that they can do it. Cultural considerations are important. That often goes into who is the decision maker in the family. And it's important to recognize that there are health disparities and different experiences that different groups in our community have with the healthcare system, and that we need to address those as well if we're going to be effective in communicating with families and making this something that is available and acceptable to them to receive. A word about vaccine mandates, and this is not related to COVID vaccine, but I think it illustrates the point. This graph shows differences between uptake of the Tdap, the Menactra or meningitis vaccine, and the HPV vaccine that are available to adolescents. And all three of these vaccines are given at 11 years of age. The Tdap and the meningococcal vaccine are both mandated and required for school attendance. The HPV is not. And we see that uptake of the Tdap and the Menactra is well above 90% versus the HPV vaccine. One dose is at 70%, and a full vaccination is below 60%, and it's even lower than that when you look at different state by state. And actually, New Jersey has one of the lower rates of HPV vaccine. But the reason I show this slide is to say that some people will get a vaccine because it's required, and if they have the choice, they may choose not to. Another example is more anecdotal, but it relates to the COVID-19 vaccine. A local health organization with 145 employees decided that they would make COVID-19 and flu vaccines mandatory. And it was they were a little skeptical about how many of their employees would be willing to comply. In the end, 140 out of the 145 did comply with the mandate, and that included many individuals who, up until the mandate, were saying that they weren't going to get vaccinated and they didn't want it, they didn't trust it. But in the end, when the mandate came around, they did decide to take it, and there was only one medical exemption. So mandates do work in terms of increasing compliance with vaccination. Schools and COVID-19 is an important issue. So we know that students benefit greatly from in-person learning, and we know that vaccination is the leading public health strategy that will end the pandemic and get kids back to school safely as our best strategy. In addition to that, though, and especially when you're dealing with now the younger kids in daycare and preschool, we need to take into account some of the other measures we can use to make in-person learning as safe as possible. And so we do still recommend universal masking in schools. They're recommending a 3-foot distance in classrooms as long as children are fully masked. And then schools should look at the ventilation of their classrooms and try to improve that as much as possible. Encourage frequent hand washing, respiratory etiquette when kids sneeze and cough, and also cleaning and disinfecting the schoolroom will go a long way to making it a safer experience for kids. We also need to encourage kids to stay home when they are sick from school, and there is screening testing that can go a long way to helping. So this is where kids are tested either universally or in samples of children on a periodic basis, weekly or biweekly, to find where kids might be positive, and then to quarantine and try to break transmission within the schools. It's also important to do contact tracing, so to know who is exposed to a positive child and to have those kids and families tested so that we can, again, break that transmission. And then there are issues of isolation and quarantine. So if a child is unvaccinated and is exposed to someone with COVID-19, they should stay home for 10 to 14 days after that exposure. The quarantine can be shortened to 7 days if a person gets a negative test 5 days after they were exposed. And if at any time that child becomes symptomatic, then they should isolate and stay home until they're well. A child who's vaccinated doesn't need to stay home. They should wear a mask indoors, and this is true for adults as well. If a vaccinated person comes in contact with a positive COVID case, we should wear masks when we're indoors for 14 days after that exposure, and that's because even vaccinated people can become infected asymptomatically and can transmit the virus. They should be tested 5 to 7 days after exposure, and again, if symptoms develop, they should isolate. So one last thing that I'd like to talk about is the effect of the COVID vaccine pandemic on other childhood immunizations. And this was a worry for us from the very beginning. Kids were not able to come to the office because many pediatric offices were closed. They were afraid to come out of homes. Even since things opened up, some people are still reluctant to come in. And so it's been borne out that vaccination for other routine childhood illnesses has decreased during the pandemic. And so we're worried about things like measles breaking out in places where vaccinations are low, or pertussis outbreaks among infants might go up because of decreases in vaccine coverage. When you look at orders for vaccines from the Vaccines for Children program, they are down compared with pre-pandemic levels. And so in Essex County, they're down 11% for non-influenza vaccines. And for HPV in particular, it's down 16%. So we know that doctors are not ordering the vaccines because patients are not getting vaccinated. And so this is another very important area that we as healthcare providers speaking about immunizations need to address and try to get those rates back up to where they need to be. Part of it was related to fear surrounding access to the vaccines. I mentioned issues with doctors' offices, and this is still an issue in some places. So many physicians went out of practice, older physicians in particular, during the COVID pandemic, when they were getting close to retirement and decided to either retire early or to really limit their practice because of either fears about COVID or inability to continue on because of financial problems. And then others decreased the number of patients that they were willing to see in a day or that they could able to see safely because of concerns about trying to space them out, not have waiting rooms filled, needing to clean rooms well between visits, and other issues like that. There were also family concerns about whether it was safe to come into the office. And then a big part of it was issues with schools. So we know that many schools were online. Some schools are still online, or they offer online options. And although kids who are attending school online are required to have and fulfill the same vaccine requirements as kids who are attending school in person, that really wasn't enforced as well as it should have been. And so many kids went without their required vaccines just because no one was pushing them to get those done. And so that needs to be, then we need to catch up on some of those backlog. So in summary, we know that COVID-19 is a serious health threat, and it's a serious health threat even to our young children. We know that vaccination is the best tool available to us for controlling illness, preventing death, and limiting spread of COVID-19 in the population. And we know that vaccines are safe and that they're effective, and we know that they're available, and we need to make them available, and they will benefit children and families, and so our job is to help them understand the benefits, encourage them to uptake vaccines, and make it something that's easy and available for them to do. And so I'm going to stop there. I'd like to I think we still have some time for comments and questions. Maybe that went a little longer than I expected.
Thank you so much, Dr. Schwab. That was a really great presentation and very informative. Before I start the questions, Dr. Schwab, would it be okay if we stay an extra 5 minutes?
Yes.
Okay, great. Thank you. All right, so I do have a few questions here. So we have a question. Why does it seem many children who are vaccinated still getting the virus?
So as I mentioned, no vaccine is completely effective at preventing infection. So the effectiveness is not 100%. Some people will get COVID and they don't develop an immune response to the infection, to the vaccine at all. Apart from that, we know that vaccines are not 100%. So some patients will get infected, but hopefully it will prevent them from getting serious illness, from becoming hospitalized. But it's really expected, and it's just part of the imperfections of science and how our bodies work.
Okay, thank you, Dr. Schwab. If a 12 to 17-year-old was to experience myocarditis following the Pfizer vaccine, what are the recommendations regarding a booster?
So once they recover, then they would still be advised to get the booster vaccine for most of the case. Oh, let me say this: the booster is available for adults right now, so there are no boosters recommendation for young people. Most of the cases of myocarditis are seen after the second dose of the vaccine, so it doesn't become a question at this point for most patients.
Thank you for that. We are hearing that an undiscernible rash is being found on children, Omicron. Do you have a resource to see what this rash looks like and what part of the body is most often being seen on?
A rash, you said, after following Omicron infection?
Yes.
That I would have to look up. I don't have a picture of that, but I can look into that and get it back to you, and maybe you can send it out to whoever asked the question.
Sure, will do. Thank you, Doctor.
To know that.
Okay. Are the children's symptoms different than adults?
So the answer to that is yes and no. So most kids that get COVID have similar symptoms to adult, with symptoms akin to a common cold or flu-like illness. So they get respiratory symptoms: cough, cold, runny nose, sore throat. What we see with the younger kids, especially infants and toddlers, is more gastrointestinal symptoms. So they'll often present with vomiting and diarrhea, maybe a little stuffy nose, but it's a little bit more towards the GI symptoms. But in general, they're pretty similar. And for adults and children, the vast majority of cases are looking like regular viral upper respiratory illnesses.
Okay. Thank you for this important discussion. Can you speak to what is being done to ensure pediatricians are encouraging and providing COVID-19 vaccines to their pediatric patients?
Yeah, so programs like this are available through our local chapter, for example, here in New Jersey of the American Academy of Pediatrics has instituted since the very beginning of the pandemic frequent weekly webinars, many of them Q&A sessions, and a lot of it is dedicated to COVID-19. And we're being sent a lot of information from them, from the CDC, to help the physician community be comfortable and up to date with the vaccine information. Vaccines for COVID-19 are available for us to give in our offices. And as I mentioned, the vaccine product, particularly for the 5 to 11-year-olds, was made with a buffer that makes it more stable in regular refrigeration so that offices can stock it more easily. Because particularly with the younger kids, 5 to 11, it was felt that the physician's office really would be the best place for them to get vaccinated, just because it's a little bit more of a challenge to vaccinate younger kids who are often fighting the vaccine and need to be restrained a little bit, and they're as you might expect, crying and shouting. It's not easy to do in a general population. I know for that, and also for just the safety of separating the different doses. Our center here at the university, even though it's a vaccine center, has dedicated hours for children after school 2 days a week, so that they're not mixed with the adult vaccine recipients.
Okay, thank you. Where do you see this mRNA advancement taking us in terms of HIV treatment?
In terms of HIV treatment, I don't know that I can speak much to that. I will say that the mRNA technology is really, from a scientific point of view, really amazing. It's a technique that can be easily modified to help the body receive these instructions to produce proteins. That's very easily kind of modified and adjusted, and it should be able to be done fairly quickly when, for example, new variants need to come up for vaccination. And I think it's a way to deliver this genetic instruction to help our bodies produce other proteins that can help us fight a whole wide range of infectious diseases as well as other conditions. And so I expect it to be something that will be utilized widely, and I would expect that HIV would be one of the conditions that would be addressed using the technology.
Okay. What happens to spike proteins after a few weeks?
They're gone. So you're talking about, I mentioned that the spike proteins last in the body for a couple of weeks. Just like any protein that your body makes, enzymes that your body produces for your bodily functions, dead cells that have replicated and then run their life, they're removed from the body and excreted. And so that's what happens to the spike protein. It's taken up by the cells that kind of quote unquote clean up debris, and it's removed. And as a foreign substance, it's taken up usually by the macrophages.
Okay, great, thank you. On the news this morning, it mentioned that ages 16 to 17 may be eligible for COVID-19 boosters. What are your thoughts?
I think that that's expected, and I think eventually, as I mentioned, we expect even the younger kids to need a booster. The vaccine does offer very good protection, but that, like with many vaccines, the protection wanes over time, and a booster can help get the antibodies and the memory back up. And right now it looks like 6 months after is the point for adults, and I expect that it's going to happen for even the younger kids once we've had the vaccines for a while and we see how long the immunity lasts. But it's perfectly expected and acceptable, and I think, in my opinion, is the right thing to do.
Okay. Well, I do know we're kind of over time, and I want to be respectful of everyone's time. So I do have a couple of questions. Maybe Dr. Schwab, I can probably send that over to you. You know, if you're able to, provide the information back. But I want to thank you again, Dr. Schwab, for a really great presentation. Again, it was very informative. I want to thank everyone for joining today's webinar. Again, the webinar is recorded and would be uploaded to the center's YouTube channel. And please stay tuned for our next upcoming webinar in January. More details about that webinar will be to come in the next couple of weeks. Thank you, everyone. Thank you again, Dr. Schwab.
Very welcome. Thank you. And yeah, any questions that anyone has, send them to Kendra, and I'll be happy to answer them individually if you like.
Thank you.
And
take care.
thank you.